is Indian Country Today.
Esquili, yes, thank you for joining us. I'm Patty Tholahungva. Dave Tenorio is home, yet still recovering from COVID-19. The 55-year-old man is from the pueblo of San Felipe in New Mexico and lives in St. Louis, where he works as a motorcycle police officer. He became sick and was hospitalized on April 1st. Tenorio was placed on a ventilator, but that didn't work. Doctors made the decision to use ECMO, extracorporeal membrane oxygenation. He's believed to be the first COVID-19 patient in the St. Louis region to be treated with ECMO and released. Surgeons call it an invasive procedure. They say it will take months for him to recover. When Tenorio left the hospital on Friday, dozens of first responders, including Chief of Police John Hayden, and hospital staff were on hand to cheer for him. The Standing Rock Sioux Tribal Council wants the governor of South Dakota to take more measures to stop the spread of the novel coronavirus. Kristi Noem, the governor, has not yet called for a stay-at-home order or closed non-essential businesses. Tribal leaders are worried about the virus coming onto tribal lands. The South Dakota Sioux Tribe's lands straddle South and North Dakota, and it's one of 9 tribes in the region. Julian Bear Runner, president of the Oglala Sioux Tribe, sent the governor a letter. He warned her about the disproportional and detrimental effects the pandemic could have on the Native American communities. The Lakota People's Project is leading a public campaign to ask people to email the governor and demand she put in place measures to protect both the public and tribal safety. A small-town mayor in western New Mexico is challenging the governor's stay-at-home order. Martin Hicks is the mayor of Grants, New Mexico. He wants to reopen all businesses, and he's ordering local police to stop any state police who are enforcing the governor's health order. The Acoma Pueblo pushed back against the move, urging the governor to enforce the stay-at-home order in Grants. The city is close to the Laguna and Zuni Pueblos, as well as the Navajo Nation. Governor Michelle Lujan Grisham says what the mayor is choosing to do is like, quote, opening up a public pool and having a P section. For the latest numbers on positive COVID cases and tests in Indian Country, let's go to Jordan Bennett-Begay. Jordan?
Patty, So over the weekend, the Navajo Nation got back from another 57-hour curfew. We're waiting for the number of citations to come back from them. But the weekends prior to that, they did give out some citations. But as of right now, the total number of positive confirmed cases within the Indian health system is 2,410 cases and 84 deaths. Again, that's 2,410 cases and 84 deaths. But since Friday, a lot of these cases did come from the Navajo Nation. That was a total of 356 cases since Friday. So that's Friday, Saturday, and Sunday, and a total of 7 deaths that happened within their nation. And the Navajo Police Department did say late Friday that they now have 17 employees who did contract COVID-19, and that's including 11 officers and 6 civilian personnel. Choctaw Nation also had 9 more positive cases, and actually White Mountain Apache had the first death of a resident on the reservation. They did have a previous death of a tribal member who lived off the reservation right now. And actually just this morning, we did find out that the Fort Apache reservation does have a total of 98 cases. That data hasn't been included within our database because we still have to, call and see what tribes these cases are coming from on the Fort Apache Indian Reservation.
That's a significant jump from Friday to today in the number of positive tests. And again, we're seeing the Navajo Nation being hit very hard by this and across the board. Is there any update on the Pueblos in New Mexico?
I haven't seen any updates as of yet, but again, this is when Indian Country Today, a small but mighty team, and using the resources we have, and we do take a lot of these cases from the emails that we receive, and also from the Google form submissions, and just people reaching out to us on social media and saying, hey, here's a link to this tribal community, can you take a look at it? And so our small team does try their best to go out and actively compile these cases from these different communities.
All right, so we have again the update on the number of positive tests in India and country. And all of that information is compiled on our platform. And we have a COVID syllabus on there as well. Jordan Bennett Begay, thank you so much for joining us.
Yeah, Patty.
And we'll be right back. Welcome back. Well, a lot of attention is being paid to people who live on reservations. In California, 90% of the American Indians living in that state are living in city and urban areas. Joining us today to talk about that is Virginia Hedrick, and she is the Executive Director of the California Consortium for Urban Indian Health. Welcome, Virginia.
Squinicoy, Nakna, Virginia Hedrick.
Well, we are happy that you're joining us here today to talk about this, but let's kind of put this all in perspective. You started this position on March 1st, and days later, California was hit with this pandemic.
That's correct. So I was appointed by our board of directors in the fall and took over as executive director in early March. Our consortium, known as SACUI, we have 10 members. They are throughout California's largest cities, including residential treatment facilities in San Francisco and Manteca.
So during that interim phase, did you start planning for the coronavirus? Because we were getting news reports probably as early as, in January, and certainly in world news that was already hitting the news in December. So were you guys putting into place any kind of action items to combat this?
A little bit. I mean, we were tracking absolutely the coronavirus in January. I think with many people, it looked a lot like SARS or MERS, which did not reach pandemic level for the United States. And so I was actually at an Indian Health Service, California area tribal consultation and urban confer when I started to realize the gravity started to sink in. One of my members comes from San Jose, which was an epicenter here in California. And while on site, 3 TSA agents at the very airport that she had flown out of had been confirmed tested positive. And I think it was in those moments with other tribal leaders and with my board of directors, did we begin to realize that infectious disease plans would need to be enacted within 24 hours. So many of our members left that meeting and put in place safety measures and put in place their infectious disease policies.
And started working towards that. So when you took over in March, at what point was the planning or any kind of implementation and process for all of your urban health clinics?
So at the organizational level, I issued a stay at home for my staff on March 9th, and we went telecommute immediately. It happened to be the same, I think it was the next day the California governor issued a shelter in place. And it was sort of a rolling measure, actually. Our Indian Health Center of Santa Clara Valley in San Jose was the first clinic to begin to shut down their facility, in that they were screening folks before coming into the facility, taking temperatures immediately, because the cases in San Jose were beginning to rise rapidly. After that, it was Los Angeles, and then our San Diego program, and our Sacramento program, and our Santa Barbara program. So it didn't actually happen all at once. As a consortium, we began to track where the cases were. As you know, with the pandemic, we started with quarantine measures. So we started tracing in California and in other states. There were efforts to trace individuals in contact, and then we reached mitigation strategies. facilities when it became impossible to trace contacts of those who had been in contact with someone who may have been exposed. When the state of California reached at the statewide level mitigation, all of our facilities had put in place and in motion safety protocols within their facilities for screening, had closed their dental operations, had stopped taking new intakes within our residential treatment facilities, and had also, within those residential treatment facilities, one measure that was very difficult to take was to allow clients to return home if they needed to or felt that would be best for their mental health. So one of our largest residential treatment, adult residential treatment, is in San Francisco, which issued a shelter in place and a stay-at-home order before the state did. And that created a lot of anxiety among clients. It is an at-will facility. And so one of the measures they took in place to allow clients, if they wanted to go home, if that was in the best interest of their substance use disorder recovery, that they could do that. That also reduced the number of individuals living in close quarters. So when we think about what kind of strategies were happening across the network, it was pretty varied.
Right, and that's another consideration when you have a treatment center where people are living there as they go through, their rehab. And for those people, how many of them actually return back to their tribal reservations?
We don't have an exact count of that, but I do know it was a large number. San Francisco has an 88-bed facility, and our Manteca facility has a 16-bed facility. And I do know that there was a number of folks who did decide to return home. And, Patty, I want to mention something that you mentioned earlier. It is true that more than 90% of American Indian Alaska Natives in the state of California live in our urban settings. And I think it's really important as a California Indian that we first acknowledge that our urban settings are home to California Indians. Among what I would consider some of the most disenfranchised. These are non-federally recognized Indian people in our San Francisco and Los Angeles places. Who are currently on that list of those seeking federal recognition who have never left their homelands. So first and foremost, that's their home. Second, we have this large population because of a federal government relocation policy that promised Indian people from large land-based reservations outside of California the promise of health, education, and welfare in California cities. And they quite literally bused Indian people from Arizona, from New Mexico, from South and North Dakota to California cities. And what it really amounted to was sleeping on church pews for a few weeks before all services had ended. California, Los Angeles itself is home to one of the largest populations of homeless American Indian Alaska Natives. So when we talk about who is living in California, you're right. It is the over 110 federally recognized tribes. It is the relocated Indian people who came here under what many would consider a forced relocation. And then it's Indian people who have moved to our cities for of their own will. They've gone there for education. Myself lived in Los Angeles for school and Sacramento for work to work with a statewide agency. So there's a number, when we talk about what is an urban Indian, it's not a singular definition. And many of us are still very closely tied to our homelands. I had an opportunity to speak to a Navajo Nation Council delegate yesterday, and in Indian country, we have long known that we are all connected. And so what's happening in Navajo is absolutely impacting family members in Los Angeles and in other places of the country.
So true. And again, so many of our families were impacted by that government policy of relocation that took place in the 40s and the 50s. So large groups of young Native families and couples were sent off into these cities, LA being one of them, Denver being another one, Chicago, and that contributed to that the high population of Natives living in cities. But we tend to go home. We tend to continue to keep those ties to our reservations, no matter where we're living. So that pull to your tribal homeland is very, very strong. So absolutely, the urban population there, and then you look at the health care and the access to health care. Again, those promises that were put in place, and in some cases, again, with this federal policy, they were not funded. So you have things like these urban health clinics, urban Indian health clinics, who are there to provide services for the people because Indian Health Services, 100% access to them and the ability to get your medical coverage taken care of through the Indian Health Services only happens if you're living on the reservation. So let's talk about the people who are accessing the healthcare that your urban Indian health clinics provide. Are they testing for the coronavirus?
Absolutely. Our Indian health programs in the state of California, our urban Indian health centers are testing, and they are working with both county and statewide testing centers to do that.
And then what about the process of the labs? Do they have the Abbott labs, or are they sending them to one main lab to get those tests processed?
That's a great question, Patty. Urban Indian health facilities were excluded from access to the Abbott testing. So within statute, we do not have access to Abbott testing. And there's a huge disparity around what our urban Indian facilities do have access to. We only make up 1% of the entire IHS budget. And you're right, the federal trust responsibility does not end at the reservation border. The trust responsibility the federal government has to American Indian people extends to any Indian regardless of where they live. And the federal government's lack of fulfilling that trust responsibility by adequately funding the urban Indian health system creates large disparities.
So where do you go from here?
You know, it's really difficult. In California, we also do not have any IHS hospitals. So when our Indian people in the state of California need to be hospitalized due to coronavirus, we are absolutely reliant on public and private hospitals. And many families are feeling that burden of what will be the out-of-pocket cost? Urban Indian health programs do not have access to purchase and referred care. Our budgets are already very small. We are serving a large population of uninsured or Medicaid dependent patients. And that's true for the tribal health system. The tribal health system here in California is also strained. It's not getting, I think the last I read on level of need funding was less than 25% was the need being met for purchase and referred care in a state that is dependent on referred care to public and private hospitals.
It's a pretty bleak picture.
It is. And, you know, one of the things that has been a major issue of mine for a long time is accurately counting how health issues are impacting Indian country. One of the things that we know in California is we have a very high rate of racial misclassification. That being when an Indian person is hospitalized and goes into the system outside of our Indian healthcare network, they are not always being racially classified correctly. Anywhere from 30 to 60% of the time is an Indian patient misclassified as being white or Hispanic. And this becomes really important because if we don't know what we're sick, what's getting us sick, and if we don't know what we're dying from, we cannot fix it.
And it ties, everything just kind of ties together, doesn't it? You know, we have a lack of media representation, whether it's in primetime programming or, you know, news, whatever. We don't see our own people in the media. And then that filters down to healthcare workers. You know, it's out of sight, out of mind almost. They don't automatically look at you and guess that you're something other than Hispanic or other than Asian. And so you're not asked those questions. Are you American Indian? Are you Alaska Native? And that kind of all ties back together. You had a great quote in some recent testimony where you said, we are being born Indian, but we're dying white. Can you explain that again?
Absolutely. Yeah. So what happens is, and many parents, new parents would know this, when you complete a birth certificate, it is a parent who completes the race category of your birth certificate. So that is pretty definitely an accurate description of someone's racial category. When a person crosses over to the other side, it is typically a funeral director that prepares that death certificate, typically with no input from the family. They're making a guess on all of those measures that you mentioned earlier, based on how a person looks, based on their last name, and they're just marking a racial category and filing the death certificate. And so those are the cases where we have seen up to 30% racial misclassification and typically being classified as white. So we are being born Indian and dying being white. And this becomes huge because if we are dying from coronavirus in California, we can guess that 30% of Indians who are dying are not being calculated that way in the state database. The state has marked as 7 American Indian Alaska Natives have died in the state of California to COVID-19. And I know that to be absolutely inaccurate. There's no reason to believe that racial misclassification would not impact COVID-19 testing and fatalities in the state of California.
Well, that's a huge difference. And again, the effort to try to make sure that American Indians and Alaska Natives are not lost in this shuffle of this pandemic. And especially when there are so many cases, not just positive tests, but also people who are dying from this. You know, a big issue on reservations is a lack of housing and how many tribal family members from one family live all together. Is that the same in urban areas? Are you seeing a lot of family members living in one home?
Absolutely. And in many cases, I think this is compacted by folks living in multifamily units, also known as apartments. So we have Indian families living in large apartment buildings, multi-generational, living with parents and grandchildren in the same home and in a large apartment building. So when we see numbers of COVID-19 rising in urban settings, it's when we think about physical distancing, you think about having your own home and having your own backyard and your front yard. But that's not the case in an urban setting. Everyone is touching that apartment complex door to get in and out, and it's a shared play space for your children, and it's shared parking spaces. And so the possibility for contacts increase in densely populated areas. And urban Indian families and communities are absolutely being impacted by that high dense population and multifamily living in close quarters.
What about having culturally significant healthcare practices? When you're located on a reservation, the healthcare provider is more aware of these tribally appropriate measures taken during a time when a person is sick and then when a person passes. In the cities, what's happening to Native people who are being taken care of by people who have no clue as to Native culture?
So that therein lies the need for our urban Indian facilities. Our urban Indian health clinics do provide that culturally competent, culturally based care with very little funding from the federal government to do that. There are Indian people, which is true outside of the cities as well, who have private insurance such as Kaiser or other HMO facilities where they're not entering the urban Indian facilities. But many of our urban Indian facilities also have community engagements where they have youth activities, where they are building systems of care specifically for our urban Indian youth. And so just because a patient's not being seen in the medical or dental does not mean that they are not receiving services from an urban Indian facility.
All right. And you mentioned that, you know, all of this is a part of a story, and we learn by storytelling. We understand what is right and wrong in our tribal communities through storytelling. What are the stories from this pandemic that are specific to Native people living in California?
I think this story starts at contact. Indian people have already been impacted by a pandemic early on when we had, non-Indian people enter our homelands. And we learned a great deal then. And much of what we have learned throughout history has positioned us in a very vulnerable space around COVID-19. It is difficult to trust the same governments who paid for our scalps, who paid for our deaths, who are now saying stay at home, who are now saying in our springtime where we're having many world renewal ceremonies happening during this time should be taking place. We have our state government saying stay at home, don't gather in groups. It can be difficult to trust those same systems. And we have to really look back to those old teachings. And this is a time where we go back to our old ways where religion and our faith is within our homes, where it can be practiced within the family members who live near and close to us, and to know that our culture can make those adjustments, that we can still continue to pray, that we do not need the four walls of a church to practice our ceremonies, that we can do that, we can do it safely, we can do it while physical distancing. I think this is a time where tribal sovereignty is strengthened, where we have seen tribes in the state of California issue stay-at-home orders. We have absolutely seen it at Navajo Nation, where we have seen tribes rise to the occasion and begin to deliver food directly to homes. It's the same with urban Indian facilities, where our urban Indian clinics are calling families to make sure they have everything they need. This is a time where our most vulnerable are being impacted in some of the worst ways. Child abuse, domestic violence, food insecurities are all being heightened throughout the United States, but these things already existed at disproportionate rates in Indian country. And so within the Urban Indian Network, we're calling those families where we know that those needs exist to ensure that they have. Do they need to drive by the clinic and pick up a box of food? Do they know where their kids can pick up school packets? This is a time where as Indian country, our close, who we are as calling and checking in and being community reliant is a strength. We know where our elders are. We're calling on them. We're making sure that they have everything that we need. And at the same time, many of our vulnerabilities are being pushed.
All right. Well, Virginia, one quick last thought before you go. What do you want people to know about this pandemic?
I want people to know that we're resilient. We will get through this, and it will take folks really being in a prayerful mode, thinking about how what they do impacts those around them. That this is a time where how we as Native people, it's not about me, it's about us, is a time that will strengthen the whole community.
Virginia Hedrick, Executive Director for the California Consortium for Urban Indian Health. Thank you so much for joining us.
Thank you.
And thank you for joining us. Take care of yourselves. Your lives are precious. I'm Patty Thalohungba. Join us again tomorrow.
This is Indian Country Today.